the key to this is psoriasis, as John Updike described, is a disease that impacts on how we interact with others, how we interact with ourselves, and it affects both our skin and internally. And John Updike, which is one of our sort of heroes, wrote about this and described his torture as skin deep. He described, I call myself a leper, I should have been smashed at birth. And this is the essence of this disease. It's not just what's happening in the skin, but its effect on people's lives, and I would suggest to you also the effect on their long-term health. Psoriasis has been with us from ancient times, so there's no point in talking about 2013 without talking about it, the past, and where did we get to here from there. And up until sort of mid-17th century, it was thought to be leprosy. And what was often described as leprosy in the Bible may well actually have been psoriasis. But the common conception was that this was infectious, and therefore people with bad skin disease were shunned because nobody wanted to catch the disease that they may have. But psora comes from the Greek to itch, and Hippocrates wrote about it and felt that people with psoriasis weren't infectious. He was unique, but nonetheless that they should be avoided, but were otherwise healthy. Robert Willen, who's Sir Robert Willen, first described psoriasis properly in the late 1750s, and he wrote it down very accurately, very diligently, and described the clinical features, and was the first person really to distinguish this from leprosy, and deserves immense credit for doing this. And this is taken from his book, and you can see that this is an artist's impression of psoriasis. And you can see where there are red, scaly areas that are separated from the normal skin. And the other important thing within this is that we know that it can often be worse in the scalp and the hair-bearing areas, and the artist, I think, gets this quite well. This man also, I think, I hope you agree, looks quite unhappy. During the 1800s, this is Hebra from Germany, who again meticulously documented what psoriasis was, and because the British and the Germans, even in those days, didn't really share knowledge, again distinguished it from leprosy, but had great success by using heavy metals, often painted on the skin, such as mercury. But his number one treatment, and this was used right up until 40s, 50s, and I think, Sarah, you said when you came back to Dublin there was the occasional patient on, this is Fowler's solution, which is arsenic. And arsenic was often used as a tonic to make people well, to pick them up after an illness, but it was also a highly effective treatment for psoriasis and dermatitis herpetiformis and a few other skin diseases. But obviously arsenic has implications in terms of poisoning, and you could even see even the guys who were selling it were telling you what to do if you should overdose on arsenic for your skin or for your general health. Some famous people down through the years have had psoriasis. I don't know if it's Stalin's famous or infamous, but Stalin is reputed to have psoriasis. And he was reputed to have been treated with arsenic. And arsenic can cause a form of dementia. And this is a paper written by Eugene Farber, who's a professor near San Francisco in Palo Alto, and felt that Stalin's psoriasis was related, influenced the decisions he made and some of the appalling consequences he had for all those people who suffered under his iron fist. So this is back to Updike again, and this, if you read this, if you suffer from psoriasis or you know people who have psoriasis, get this. This is available in the New Yorker from 1976, and it's called At War with My Skin. And far more eloquently than anybody else that I've read, he describes the impact of psoriasis on him as a human being, on the choices it made for what he did within his life, how his relationships changed because of it, and how he treated it, and how the sun was his friend. And this picture depicts his feet sticking out as he lay on the beach and trying to burn his psoriasis away. And we would hope that in 2013 that we can achieve better control for people. But if you're of a younger age, this is Kim Kardashian, who's a supermodel. Your children, maybe some of you follow the Kardashians on television. In fairness to Kim Kardashian for a supermodel, because a lot of people keep their psoriasis secret. They don't tell you they have it. She's been very open and upfront about her psoriasis. And she's a good example that you can become a supermodel and have psoriasis. And with correct modern treatment, there's no reason that you can't enter any profession. And the reason she's got flares on her legs is because she stopped her treatment when she became pregnant. Similarly, a rather famous golfer has also got psoriasis and also got psoriatic arthritis. And I can't do that with a golf club. I certainly can't play the golf he does. But again, with modern treatment, there's no reason that anybody can't fulfill a normal, healthy, proper life. And that is the goal of treatment. But we'll go back to where we're coming from. Hebra was famous for arsenic, but really the first professor of dermatology, as Sarah touched upon, was Ingram in Leeds and then subsequently in Newcastle. And again, you can read his writings on this in 1953 in the British Medical Journal. They're available on the internet. He speaks passionately about the need to keep people clear, to clear people with this disease and to keep them clear. And also, interestingly, in the relatively early days of the National Health Service, the need for this sort of service to be funded correctly so that, as he describes it, this devastating disease didn't impact on people's lives. And he pioneered inpatient treatment with Ditronol and Lasser's paste. And Sarah and Louise and Rosie Watson in Hume Street, but predominantly most of Sarah's patients, and if those of you who are patients who were in Hume Street got Ditronol, 95% of patients could clear, and the average remission was 6 months. But it needed 3 weeks in hospital. And I certainly remember my days as a student in Hume Street, and certainly as a registrar, there would have been 30 people in, the majority of whom would have been getting this treatment, a highly successful, safe treatment. And this is an example of Ditronol being put on, and it's messy. And any of you who are familiar with Ditronol will know, as Sarah said, it'll stain the curtain, the shower curtains, the bath, anything it gets onto. But it can be highly effective, and it leaves behind these brown marks which will resolve if the psoriasis stays clear. But it can burn you a little bit, and just a tad. This gentleman feels quite comfortable, but actually it looks quite dramatic. And this is more indicative of his severe psoriasis, but also one of the downsides of treating people with Ditronol. This is why this had to be a hospital-based treatment. Ditro cream was also used as an outpatient as a short contact area, but again, as we said, can burn to sensitive areas particularly. At the same time that Ingram was doing this, even before this, this is the only picture I could get of William Geckerman, which is of his grave. And I'm not sure why that's true. But he was pioneering inpatient treatment at the Mayo Clinic with topical tar treatment, low-dose UVB, and again, inpatient. And in the United States, and particularly in the Mayo Clinic, you can get Geckerman regimen even today. We cannot do that in Ireland because we do not have the facilities to do it. And once again, remission could be achieved. This is the key. It's not about getting people just clear, it's about keeping people clear. And over 90% clearance rates. And again, this was done regularly in Hume Street. But tar is a messy thing to do at home. It's black, it's horrible, it's not something you'll put on and go out on a date. And this is just nursing treatment with tar for bad psoriasis. This is a nice picture of an artist who did a picture of Hume Street, and some of you will be familiar with this. And Hume Street really was the centre in Ireland, and certainly one of the centres in the UK and Ireland where inpatient treatment was done at its highest level. Having worked in other places across the world, Hume Street did this as well as anywhere else. And Sarah's taken half my talk, but as she alluded to, she set up phototherapy when she came back to the UK, came back to Ireland, and we now have very good, effective phototherapy treatments. And Hume Street really was the gold standard for Ireland, but certainly across the world as well. And pioneered by Sarah, there were several research publications moulding this treatment to make it safer for patients, to make it more effective. So what we have in 2013, and the majority of our patients are still treated with this because it works very well, is Narrowband Uvb. And this clears 94% of people. These are people that we have, when we've looked back at our figures, and the average remission achieved is 6 months. But the problem with this average remission is some people only get a few weeks and some people get a long time. And I had a gentleman come to see me and he knew I was going to tell people about this. And I had seen him as a student with you, Sarah, in Hume Street 21 years ago. And the first time his psoriasis came back was 20 years later. So there are some people who get prolonged remissions, but there's a limit to the number of treatments that people can get, because if we go beyond a safety limit, the risk of skin cancer increases. But under that limit, and this is also really important, the skin cancer risk doesn't. So we can treat quite safely up to this, and the research that's been done in this is pretty robust. Similarly, some of you will be familiar with PUVA, which is P, which stands for psoralen. That psoralen is a chemical name. It's got nothing to do with psoriasis, bizarrely enough, even though it's spelled very similarly. And that's combined with long-wave ultraviolet light at a very low dose. And again, Hume Street pioneered some of the changes in this. When this was originally developed in Boston in the 70s, it was given every day to people. Then it was reduced to 4 times weekly. And one of the studies that I was privy to with Sarah, we showed that actually twice weekly works. And this is obviously of enormous benefit for the patient. And also a big, enormous benefit for the hospital, because you can treat more people if you're just treating people twice weekly. Again, we know that over 90% of patients will achieve clearance, and the average remission, again, is that magic number of 6 months. But again, we know there's a limit to the amount that we can give. Below that limit, there's no increased risk of skin cancer. Above that limit, there is. So we need to move on. People with moderate to severe disease start here and then moved on. And you can just get 10 courses in your lifetime on average. But a wonderful, wonderful treatment. And this is what these machines look like if you're not familiar with it. The top 2 are hand machines, so you can treat localized psoriasis to either the hands or feet. The bigger machines, which you can see, they look like stand-up sunbeds, although they're not sunbeds, and this is absolutely important. Sunbeds produce the wrong wavelength of light for psoriasis. They have minimal effect. They produce the right wavelength of light if you want to give people skin cancer. And this is the opening of the daycare unit that Sarah spoke about in Hume Street with Barry Desmond, who was then Minister for Health, and I think Sarah's recognisable within this. This is the dermatology daycare centre that I went to as a medical student. For some reason, this is clicking on its own. And I had great times learning about psoriasis, learning about PUVA, but even better times being taught the price of women's shoes, that odd socks weren't acceptable, and Felicity, for those of you who are familiar with it, told me that blue and green should never be seen without a colour in between. I have no idea what it means. I still make those mistakes today. Great fun and great place. And to the extent that in 1986, the Irish Times picked up on the really revolutionary change that was happening here in terms of treatment of psoriasis. You now had really robust inpatient treatment, as good as anywhere else, and the sort of daycare and phototherapy unit that was matched certainly anywhere in Ireland or the UK at that time. So let's get back to psoriasis and some figures. It affects about 2 to 3% of the population, and about 20% of people will have moderate to severe disease, and that's the core group that we end up seeing. It causes, to put that in context, that's about 25 to 33,000 people in Ireland, in the Republic of Ireland, have moderate to severe disease. It causes significant psychological distress, and that interlinks with psoriasis, because psychological distress, as I will show you, can make psoriasis worse by changing the immune system. It reduces the quality of life of its sufferers, and studies have shown that this is more so than people with diabetes, angina, blood pressure, asthma, and some cancers. And the reason is, as a gentleman told me one time, who, when we were giving him cyclosporin, and cyclosporin could cause stress in the kidneys, and I told him we were going to have to change because his kidneys were going to get damaged from the drug. He said, I don't care about my kidneys. Nobody sees my kidneys. Everybody sees this. So the impact on your quality of life and how you live your life is significant, and this has been proven scientifically. So what's happening in the skin? The bottom is the normal skin. So what's happening is that you start at the basal layer, and I'll walk over here just to demonstrate it, and your skin reaches the top layer, dies and falls off or exfoliates quite naturally, doesn't need the cosmetic industry, and that happens about once every 28 to 32 days, depending on, we all vary. In psoriasis, it doesn't take a genius to work out that the skin is hugely thickened. And you can see the little blue or black dots. These are cells of the immune system that are causing the skin to thicken. And the cells turn over a lot quicker. And in an average of psoriasis, it's about 4 to 4.5 days to get from the bottom to get to the top. And because the cells are immature, they stick together. And that's why it's scaly. So they take longer to fall off. And because of the inflammation driven by the immune system and new blood vessel formation, we see this as red plaques. So there are various types. This is the most, probably from a scientific and clinical perspective, the most basic type, which is called guttate psoriasis, which often occurs in teenagers, particularly after a sore throat, where again the immune system seems to respond to any infection that it gets, and in those people who are predisposed to this, it causes extra immune activation in the skin. That's what psoriasis is, excessive immune activation in response to various triggers, including streptococcal infection. But there are various varieties. This is a very rare variety, but the most life-threatening one, which is called generalized pustular psoriasis, unfortunately is very rare. But often when you're talking to funders and you're talking to politicians, they go, oh, skin disease. Nobody dies from that. Unfortunately, the occasional person will get profoundly unwell and die from psoriasis. And this is the variety that can do that to them. But this is the more common garden variety of psoriasis that people will be familiar with, affecting the scalp, affecting the elbows, affecting the knees, affecting the soles of the feet. Similarly, it can also affect the nails, and you can get pustular psoriasis where it affects the soles of the feet. And people will tell you, and if there are anybody who's got it here in the audience, that these little yellow lakes of pus, which are not infection, this is just overactivity of the immune system, are like walking on shards of glass. But we also know that psoriasis is associated with other conditions, including psoriatic arthritis, which is an immune-driven arthritis that can act like rheumatoid arthritis, and you can see that the small joints of the hand in that picture up above are quite swollen and painful. But most patients that come to see us have commoner Gardner chronic plaque psoriasis. And it's not, doesn't take, a huge amount of imagination to, if this is in an 18-year-old guy, that life is going to be difficult and functioning is going to be difficult if this is what your skin's like. So as I said to you, and I'll try and avoid the sciencey bits too much, but the bit on the left is not psoriasis skin, it's the bit that looks clear. So, and then if you come down to B, so it's called non-lesional. If you remember the picture I showed you earlier, it's lesional. And then when you treat people with various things that lower the immune system, the brown dots are the immune activation, and when they disappear, the skin disappears and goes back to normal. So if you can target the immune system appropriately, you can clear psoriasis. And this is the key to this. And again, this is a very sort of technical slide, but we have two bits to our immune system. Our immune system is there to fight infection. But in the skin and psoriasis, it's overactive inappropriately. And we get various cells of the immune system that interact with the top layer of the skin that produces chemicals that cause more activity of the immune system, that produce chemicals that cause more activity of the upper layer of the skin. So you get a vicious circle. So once this is triggered, it's often self-perpetuated until we can do something about it. Well, what I would argue in 2013 is that this inflammation or this overactivity of the immune system, that psoriasis leaches from the skin into our system and can influence other diseases associated with psoriasis. Now, it's a rather ugly phrase called comorbidities, but that's what we've been given, that's what we're stuck with. But there are other things that people with psoriasis get more than the normal population. And the concept and the theory is that inflammation or overactivity of the immune system causes both the comorbidities and the psoriasis, but that the psoriasis influences the other conditions, and I'll explain this more. And that the basis for this disease and the basis for most immune diseases are we are built with our genetic code, that's us. But that certain bits of our genetic code predispose us to getting psoriasis, and then that interacts with our environment. So like the picture of the 18-year-old guy with the little dotty psoriasis, that often is triggered. The genes have been there for 18 years, he gets a strep sore throat, and his psoriasis gets worse, or it triggers it. And that triggers that perpetual cycle of immune activity within the skin. So the trigger is there, the genes are there, and I want to talk to you briefly about what they may be. But these are the conditions that we recognize to be associated with psoriasis. Psoriatic arthropathy, or this inflammation of the joints. In patients with severe disease, this is anything up to 30 to 40%, but probably it's in the order of about 15 to 20% across the population. The bigger a person is, the more their psoriasis worsens. So if we put on weight and we have the genes for this, it can make the disease worse. And the combination of the two can affect things like blood pressure and angina. As I alluded to earlier, psoriasis can cause huge amounts of psychological distress. But to complete the vicious circle, psoriasis itself causes psychological distress. And the distress can make the skin disease worse. 8 out of 10 people will tell us this. We also know that other immune diseases, such as Crohn's disease, which is an inflammatory bowel disease, or celiac disease, which is a gluten-sensitive, again, intestinal disorder, are commoner in those patients who have psoriasis. So if your immune system is prone to giving you psoriasis, it may be prone to giving you other immune-based diseases, and uveitis is a disease of the eye, which again is common in those people with psoriatic arthritis. So this is a slide that I borrowed from Oliver Fitzgerald, showing that it's not just the skin, that there are inflammation in the joints where you can see swelling of the toes in the bottom left, swelling of the hands, and the x-rays show joint damage, that when this arthritis is severe, joint damage results, but also people can get eye problems, and it's not just a skin disease. Therefore, it's not just a skin disease, we need to be thinking beyond the skin when we're treating it. And again, to come back to this is a systemic disease, and we're going to briefly talk about the genes because it's one of the commonest things that people ask about, and it's probably the next great revolution that's going to happen to psoriasis. We've known since the 60s that about 2 to 3% of the normal population have psoriasis, but anything to up to 7% people will report a positive family history. And if you're a geneticist, twin studies are very interesting because you've got two sets of types of twins. You've got identical twins who've the same genes, and then you've got non-identical twins who've similar genes because they're brother and sister, but they're not, or brother and brother, or sister and sister, but they're not the same. And what they showed is that if your identical twin gets psoriasis, you have a 72% chance that you will get psoriasis. But if your non-identical twin gets psoriasis, it drops to about 15 to 23%, depending on the study that you get. So what that suggests is that genes play a very important role in this, because it's nearly 3.5 times higher in those people with the same genes compared to those people with similar but different. And therefore, but also that your environment is important in this pathogenesis as well. And there was this concept that the genetic was very important in those people who got psoriasis early, before the age of 30. And again, this work dates back to the 80s and has been further refined in the 90s and 2000s. But this is the up-to-date. This is published December 2012, and I'm not going to go into the varieties of these, but these are the sort of genes that we now recognize are associated with psoriasis. And one of the great privileges we've had through Sarah's work in Hume Street, our work in Vincent's, and in collaboration with our colleagues in James's and Galway, is that we contributed over 900 samples to this study, which was a worldwide study of 3,000 patients. So Ireland was punching above its weight. And again, this is all very technical stuff, most of which I don't understand. I'm meant to know something about it. But if we go back to this immune system, innate and adaptive, the ones with the stars are where your genes are different to the normal population, in inverted commas, in those patients with psoriasis. And that these genes seem to code for changes in our immune system. And it's estimated now, because when we started this work, when I worked for Sarah in 1995, it was hoped there'd be one gene. We find one gene for psoriasis, we target that gene, it all goes away. The bad news is there's going to be about 35 to 40 genes. And this only accounts for about between 1/3 and 40% of the heritability. Nonetheless, this tells us an awful lot about what's going on in the skin. So the gene studies would suggest, as I've told you, that our theories about the immune system being overactive are absolutely correct. These genes instruct our immune systems how to behave to the probable normal functioning of our skin, and that produces psoriasis. We would hope that the consequences of this are going to be that when people come to see us, some say 5 years, but certainly you would hope within 10 years that we will be able to rapidly sequence their genetic code and able to decide what genes are malfunctioning and therefore be able to target treatment better. Not for just to target treatment, say you're going to do well with this treatment, you won't do well with this treatment, actually we won't give you this treatment because your genes will say you're going to get a side effect from it. That isn't here now, but it's certainly within touching distance. And this work has contributed to that. And this goes back to, we know that some of these genes are commoner than in people with CD is Crohn's disease, RA is rheumatoid arthritis, CED is celiac disease, AS is ankylosing spondylitis, which is another form of arthritis. So other immune diseases carry these same genetic markers or the same genetic code, but psoriasis seems to be different in certain ways. So the next bit then are the environmental factors. What makes us, so if I've got the genes, I know I've got the genes for this. In 10 years' time, I'll be able to go to hospital and somebody will just take my genes and tell me what genes I have. What environmental factors make this worse? Well, the one I'm going to concentrate on tonight is stress. And shortly after I moved to Manchester, for most of those people who lived in Manchester, a shocking and awful event occurred, which was that Manchester United won the European Cup. And if you've ever been to Manchester, most people in Manchester hate Man United and they support the Blues. And about 48 hours later, this guy came to see us, and he was red from head to toe. And usually if this happens to somebody with psoriasis, he said he had very stable psoriasis. Until this, something big has happened, big infection, a reaction to medication, or a major stressful life event. And he said it was United winning the European Cup. And I said, it can't be that. You were alive in 1967 and they won the European Cup, or in 68, and he said, yes, but they won the treble that year. And his quote was that he didn't cry when his parents died, but he cried for 8 hours solid when Man United won the European Cup. Now, this is true. It's a story to illustrate that stress does play a role in this, and there is a science behind this. Stress changes how our immune system works, and I won't labor the whole diagram, but some of the chemicals that are involved in making the skin into psoriasis, which are called cytokines, can also influence our mood. And similarly, our mood can influence our adrenal gland, which produces our own cortisone, which changes how the immune system works, and specifically the chemicals that are cytokines that are involved in the production of psoriasis. So once again, you can see this virtual circle, or this vicious circle. And we know from talking to people that 80% of people will tell you that psoriasis gets worse when they're under more stress. And if you find a cure for stress, please tell me. We'll make a small fortune together. But we also know that psoriasis causes stress. And as I've touched on, a vicious circle ensues. But if you look at this again on a scientific level, because if I go to James Riley tomorrow and say, listen, psoriasis causes stress, he'll go, where's your proof for this? But there are multiple studies, some of which we've contributed to, showing that feelings of stigmatization are higher in those people with bad psoriasis, that incidence of depression and anxiety are higher in those patients with bad psoriasis, and that we as dermatologists don't pick up on this, and that it has profound effects on social interactions both at home and in the workplace. And we also, this is a similar study, and this compares to normal, and about nearly 1.5 times more likely to get depressed if you've got bad psoriasis than those in the normal population. And you can see our theory would be that the overactivity of the immune system influences mood, and that similarly again with stress and anxiety, this is increased. This also seems to affect us at a younger age. So the grey bars on the left are those people from 18 to 34 years, and those on the blue bar are it says 35 to 54 years, and then those are more than 55 years are in yellow. And you can see that these are, how does it interact with your workplace, family, friends, public activity, getting a job even? And that the younger you are, this is a higher impact. And again, this scientifically proves what we probably all know. I think psoriasis in your teens is a devastating disease. We've done this in our own populations, and it's estimated that about 30% of our patients worry too much, 10% are depressed, but it's estimated that 100 patients a year kill themselves in the United States directly due to psoriasis. Now, to me, as somebody who's interested in this and treats this disease, this should not happen. We should be able to achieve sufficient control that this doesn't happen. So how does this work out? Again, if you look at this scientifically, for those of you who've gone for UVB and those of you who've gone for PUVA, the number one predictor of whether you're going to do well or not is how anxious you are, and it may be about your psoriasis, and how worried you are about your psoriasis. Interestingly, not how bad your psoriasis is. This is a study we did in Manchester back in 2003. And similarly, we repeated this study in Hume Street, Vincent St. Tala with Narrowband Uvb, and again showed the same thing. Some of you who are here will have been involved in these studies where you've filled out questionnaires before and after treatment, and we know that the more anxious and the more stressed you are, the less well your psoriasis does. This vicious circle keeps on coming. And again, this is another diagram showing you the same thing, that the brain influences your cortisol levels via a thing called CRH. Don't worry about what it is. It's not the company with the high share value. It's a biochemical that's produced in your brain. And we know that we produce less of this chemical when we've got bad psoriasis, when we're stressed, compared to, inverted commas, a normal population. So part of my job in Manchester, and this was kind of fun, some patients enjoyed it, some didn't, it's where we stressed people with psoriasis. And we measured their cortisol levels. And you can stress people, like I'm stressed now talking to a full room. You can stress people by asking them to do mental arithmetic. Take 7 from 293 and keep going in front of a crowd of people they've never met. And you will get a cortisol response to that. If you've got bad psoriasis, the cortisol is blunted. It's abnormal. And it allows the immune system to be too active and may well produce what's happening in the skin. And this is mirrored in lab work or lab rat work, and these are fun. These are called Lewis and Fischer rats. When I say fun, I don't have them at home or anything. But what's interesting is these rats were bred for their temperament. The top rat is quite anxious. So what they did was that they interbred rats that were anxious, and they did this for generations, and they did it with the other guy who's a bit more sort of chilled out and watches the television. And we know that the people who are the rats that are more anxious are more likely to get autoimmune disease or inflammation, and the guy who's more relaxed isn't, but he's more likely to get infections. So the more stressed we are, the more anxious we are, the more our immune systems are more prone to misfire. And this may provide the connection that we have between stress and psoriasis. And indeed, some work that Maureen O'Kane, who's a consultant in Beaumont, did, looked at this chemical that's in your brain in response to stress is also expressed in psoriasis. That this is the brown dots are a biopsy from somebody with psoriasis, showing that this chemical is upregulated. Don't worry, the below ones are normal controls, but the one beside it is normal skin, and it's not expressed. So we know that there is a clear connection between psychological distress and immune function in the skin, and this is one of the reasons we think psoriasis gets worse with stress. So what can you do about it? That's all well and good. You've got nice, fluffy, anxious lab rats, and you've got the relaxed rats. What can you do about this? And again, I will briefly look at this. This is again a study we did in Manchester looking at relaxation or stress management in the management of psoriasis. And this is patients, 40 patients in yellow who had normal treatment, and the axis isn't showing up very well there in the slide, but PASI is a measure of how bad your psoriasis is. It's called the Psoriasis Arian Severity Index. How much psoriasis do you have? And if you come along to our clinic or you come along to our phototherapy, you'll know that we're there doing mathematics on a page every so often, and we come up with the score. And that's what's called the Psoriasis Arian Severity Index. It's how we measure it. And we know that people with standard treatment got better. At 6 months, great, the amount of psoriasis they had disappeared. And then as time went on, it started to relapse. But when we compared that to those people who got standard treatment and had a stress management program, who dealt with the stresses that we all have in our lives, that their skin was a lot better. But also this thing stopped after 6 weeks. 6 months later, their skin was still better. So it suggests that if we intervene at the stress level, we may help to the physical disease to get better. And other people have done this. This is, this is fun. It's something we attempted to do, but we couldn't. This is from Ghent. And there's a wonderful lady there called Professor Lambert, who's the professor of dermatology. And she's devised a life stress management program for psoriasis, which involves yoga, as you can see, meditation, dietary advice with regards to losing weight, because as I said to you, the bigger we get, the more severe our psoriasis gets. Education about psoriasis, and she's shown that this makes people feel better, less stressed, but also their skin disease improves. But it is a very difficult and expensive program to run. So we've tried to do this in a different way, and again in a scientific study. Unfortunately, this is not the sort of thing that the HSE will fund. So we get research money in to do this. But this is to look at a thing called mindfulness. I don't know if anybody's aware of mindfulness. Mindfulness is the buzzword in psychology at the moment, and has got very impressive results in people with depression, but also got people with post-myocardial infarction or heart attack. If you're a man and you have a heart attack, you're a 50% chance of getting depressed, seriously depressed, within 6 months. Mindfulness seems to have that risk. So we said, well, why don't we see if we can do this in psoriasis and see what helps, or see if it helps. And I'll simplify this, but these are depression scores before and after, and the green people are the green people should be the mindfulness group, and the blue people are the controls. But essentially what we've shown is that with mindfulness, you get a reduction in depression scores, you get a reduction in anxiety, and you get a reduction in worry. And one of the things that may be awry in terms of the psychology and the depression in psoriasis is self-compassion. You heard John Updike saying, I should have been smashed at birth. There's a sense of hating himself because of his psoriasis. And we know that people, compared to those people who didn't want to do this program, that those who went through a mindfulness course for 8 weeks, their self-compassion improved. But from a scientific point of view, there's a thing called telomerase, which is a marker of how our immune system works. It's a very non-specific marker. But in those patients who did the mindfulness course, this marker of their immune system function seemed to improve. So not only do they feel happier and better, but their immune system seemed to be responding and be healthier afterwards as well. This is early days, but it's an idea and an indication of how environmental factors can influence the immune system and influence the disease. So we'll go back to this chap. I took this photograph when I was in Manchester, and this gentleman knows that I showed this photograph in lots of talks. And when I took this photograph, we were concerned this man's got pretty awful psoriasis. And at the time, he was on pretty heavy-duty treatment. But one of the things that we just wondered about at that stage was his skin. We were less concerned about how depressed he was. We were less concerned about how stressed he was. We wondered about his joints, but we didn't do a lot about it. And we certainly didn't worry about his heart or how big he was, because it's quite obvious that the man's overweight. And if you look at the immune system in the blood vessel in your heart, and Professor O'Brien is a cardiologist, so please stop me, Owen, if I'm getting this wrong, but your immune system is also active in the blood vessels of your heart when you get coronary artery disease. And a lot of the cells and a lot of the chemicals or cytokines that are active in your skin may also be active in your coronary arteries when you get cardiovascular disease. And we know that people with severe psoriasis are more prone to getting cardiovascular disease. And this is some epidemiology studies which show that particularly those people who are young with really severe disease are more prone to getting early heart attacks. Now this is really important. This is epidemiology. This is association. It's not causation. You don't say psoriasis causes heart attacks. We just observe that people with bad psoriasis seem to be getting heart attacks at a younger age. Is this due to the psoriasis or something else? We don't know. But this is where we're at in 2013. And we know that this seems to be common in those people who are overweight. And remember, 27% of the Irish population are termed to be obese, 1 in 4 of us. And psoriasis seems to react with obesity and inflammation or too much immune activity in the blood to change how your insulin works and to give you early atherosclerosis or coronary artery disease. And when we've looked at this in our patients, BMI is, as you know, is body mass index. And as we get bigger, the other thing is PASI, your psoriasis gets worse, and that's particularly true if our waists go. You've heard the phrase, his chest has slipped as the years have gone by. Abdominal obesity, so there seems to be a concept of bad fat, which is that bit around your tummy, and relatively good fat. And if you just simple measure your waist circumference, you can tell that those people with a bigger waist circumference have worse psoriasis. And this may have implications for their heart. We certainly know, and this is not in people with diabetes, that it changes insulin resistance. And insulin is a hormone we produce in terms of to control blood glucose levels, but it may be important in damaging blood vessels and causing early heart attacks. And we know that the worse the bigger people get, the more they get insulin resistance, the more likely their disease, their skin disease, is to get worse. So what we're saying is that in 2013, when we see the gentleman with bad psoriasis, that we shouldn't just be looking at his skin. I'll tell you how we get his skin better in a minute. But we should also be screening for those things that may cause cardiac disease, such as diabetes, blood pressure, lipids. We should be telling everybody that comes to see us not to smoke. If they drink too much, because that damages your heart, that should happen as well. And one of the interesting things is depression and stress, but particularly depression, is an independent risk factor for getting early heart attacks. And we should be finding out, and we do now screen for depression to see if we can manage this better. So it's not just a skin disease. But what can we do about the skin disease? Because I suspect that's what half of you are here for. You're not here to listen to me talk about immune systems. Methotrexate came along in the 60s, and what was recognized is methotrexate was a lifesaver for children with leukemia in the early 60s. Unfortunately, if you got leukemia until the early 60s and you were a child, you died. Thank God nowadays cure rates are of the order of 90%. Methotrexate was the first step along that way. And because psoriasis skin turned over quicker, and in leukemia what's happening is that the cells in your blood are turning over quicker, somebody jumped from A to C and said, well, why don't we try this drug for people with psoriasis? And methotrexate is one of the mainstays of treatment that we use now, but we use it in a fraction of the dose that people use for leukemia. And this essentially shows that up to 3/4 of people will get a very, very effective response to once weekly methotrexate. But there's no such thing as a free lunch. You need monitoring with this, and particularly for liver and bone marrow. But methotrexate, the analogy I use is like a car. If this is used properly, in the right patients, at the right time, it is extremely safe. We'll see the warning signs coming. The only problems that we've ever run into in the last few years have been patients who haven't been monitored, and they have then developed issues. Sarah remembers when acitretin came along in the 80s, and this was neotigazine for those of you who may have ever taken this. And this is a vitamin A derivative. And again, this promised wonderful things for psoriasis because it stopped the too much turnover in the top layer of the skin. And for a small percentage of patients, this can help. But this study goes out to about a year, and that's what these bars look at. It actually shows that most people will come off it after a prolonged period of time because the side effects of it are too miserable. So you want to treat your skin disease, but you don't want to have the sort of side effects that make your life miserable. But for some patients, this is a wonderful treatment. Fumaric acid esters are probably the one drug now that we use first line for patients with moderate severe psoriasis, where phototherapy isn't either practical or it's not working, or when people have reached their limit. And up to, this is looking at, in terms of, that's the number of patients, but about 73% of patients, 75% of patients get a wonderful response with this. Some people will feel absolutely awful when they take it, absolutely dire, and you can get diarrhea. I had one girl in England who phoned me from a toilet, and she said she wasn't leaving. But it's rare for that to happen, and those side effects are imminently reversible once this medication stops. But to give you an idea, in St. Vincent's at the moment, we've about 185 people who take this drug who are well controlled while taking this drug. But again, it needs monitoring because it changes things in your immune system, such as your white cells in your blood, and we need to know where they're at. The majority of people will do well in this. And what I'm trying to share with you is that this disease is controllable. And I'm then going to move on to the high-tech ones. These are the injection ones. And again, this is a complex immune diagram. But what I want you to concentrate on are the phrases IL-12, which is a chemical we produce in the skin, too much in psoriasis, TNF-alpha, IL-22 and IL-17. So these are all chemicals that we have too much of in the skin with psoriasis, and there are treatments that stop these. And these are the injectable or biologic treatments. And they stop these chemicals from working, and they help the skin considerably. And these are the modern ways. So that when methotrexate, acitretin, cyclosporin to a lesser degree, and fumarates don't work, we have these. And these are the ones that are licensed and available for use in Ireland. They're called infliximab, etanercept, adalimumab, and ustekinumab in no particular order. These are all, they have fancy names for specific reasons, but AB is antibody. So what happens is you have a protein that binds to these chemicals, switches those off with resultant improvement in the skin. And again, this is complicated, but what I want you to concentrate on is the bit on the left, which shows the number of people whose skin improves by 3/4 or more when they go on these drugs, and then how that persists as they go out. And it's quite a busy slide, but the essence of this is somewhere between 50 and 80% of people within a relatively short period of time, depending on the drug, will get more than 3/4 of their psoriasis disappear, and they will maintain that treatment going out. And if you look at this, this is for one specific one, and again, this doesn't look at this, looks at through week 160, so that's 3+ years. And it looks at the people who got to 3/4 and how it persists, and for the most part, they maintain that response. And PASI 100, which is the blue line, means you've no psoriasis left. There's none. It's gone. And in those patients who make that with this medication, they keep on going. And that's what we should be able to achieve in 2013. Similarly, this is a different one, which again inhibits TNF-alpha. And this is a study showing that this works for the skin and it also works for the joints. And anywhere between 60% of patients using this twice weekly will get an excellent response and will maintain that response. And what's reassuring in 2013 is that the long-term safety of these drugs seems to be well worked out. They don't seem to have caused us major concerns. There are people who will get sick when they take them, but nonetheless, we seem to be able to predict who those people are, and we seem to be able to treat the illnesses. They still carry a small risk, but I would suggest to you it's of the order of driving to Cork this evening. And similarly, this is the latest one, which is ustekinumab, and again, it shows you that most people get a fantastic response, and that response lasts out to 148 is over 148 is over 3 years, or nearly 3 years. 156 is 3 years. This is where 2013 is at, because these drugs are not available. These drugs are in trialing. And if I click on these new ones, which will be coming to us, we hope, within the next 2 years, inhibit this thing called IL-17. And I'll go back, and these are published, these are in the public domain. There are 3 of them, I've just picked 2 of them. But PASI 75 at 12 weeks, so 3 months after you start these, somewhere between 75-80% of people will have 3/4 of their psoriasis gone. 3 out of 4 people, or 75%, will have 90% of their psoriasis gone. And somewhere around 60% will have no psoriasis left whatsoever after 3 months of treatment. Now, the long-term safety of these remains to be established, but nonetheless, this is the most exciting. This is an injectable drugs. These are all injectable drugs. One way you may have to come to hospital for. The other 2 can be able to done at home. But they are the most effective things that we have seen for psoriasis by targeting this, bit of the immune system called IL-17, which is that box there. And that to date, this is the best drugs that we have. And they were going to be along the line between 18 months and 2 years. So what I hope I've shared with you is that psoriasis has come along from when we thought it was leprosy, to giving people arsenic, to giving people methotrexate, to the wonderful treatments of phototherapy and PUVA, to the inpatient beds which are no longer with us but did work, to a more modern scientific targeted treatment. Now, we still use everything else apart from the arsenic, I might add, because they all work well and have long safety records. But for those people, because if you see 70% of people do well with methotrexate, that means 30% don't. So what do those 30% get? We give them fumarates. 2/3 of those get better. Then we've left with 1/3. They go on to the TNF inhibitors, they go on to the next. And we are now at the era, I would suggest to you, that where everybody who comes to us in the medium to long term, it may take a couple of years, we will be able to control their disease for the vast majority of people, if they are willing to take these medications and balance the side effects and the potential side effects and life issues with them. But what's also exciting is that we're also going to collect data about this. And this is a study we're involved in Vincent's, but also the numerous studies across Ireland, where we collect information, and some of you in this room may well be involved in this study, anonymously, and share it with our colleagues in the UK, because in Ireland we're too small to do this on our own, to learn more about the long-term effects of these medications, but also to learn about the long-term effects of having psoriasis in terms of whether people with psoriasis really do get early heart attacks, whether treatment changes this, whether psychological issues like depression, anxiety can go away on a long-term basis when you clear the skin. My firm belief is that they can. And this requires an enormous amount of work, an enormous amount of investment on behalf of the British Association of Dermatologists. And in Ireland, you can see the centres that are involved. And again, without knocking the HSE, are not something that they are interested in funding. We need to get outside funding to do this. So I hope that the future for psoriasis from 2013 on will look at the individual's needs. How are we going to keep your skin clear? How are we going to keep your skin from being an issue in your life? How do we manage the associated psychological distress in conjunction with your medical problems? How do we find arthritis and treat it? And in the future, as I had said to you, in 10 years, when people come to see me, I hope, we will be able to take a blood test, look at how your DNA functions, and pick on the correct treatment for you. And the paths are opening up for that. But psoriasis is just more than a skin disease, and the dermatologist is at the centre looking after this. But we need to be looking at things like rheumatology, joint disease, early heart disease in those people who are prone. Those people who are obese, how do we sort it out? Looking at depression in terms of psychology, so that we can get at early detection of issues like arthritis and coronary artery disease. We can intervene and we can treat better. And therefore prevent damage prevention in terms of joints and the arteries, but also damage prevention in terms of patients' lives being ruined by this awful skin disease. Thank you very much.